number 3. Good morning. Thank you again for joining us for our ACRVF Treatment Guideline Conference. This breakout session will address the treatment guidelines that were developed for EGPA. I'm very pleased to welcome Dr. Carol Langford as our speaker today and Dr. Phil Sayo as the moderator of the session. Dr. Langford is the director of the Center for Vasculitis Care and Research at Cleveland Clinic in Cleveland, Ohio. Her work focuses on patient care and research in vasculitis. She explores many of the different vasculitises, including GPA, MPA, EGPA, PAN, giant cell arteritis, and Takayasu's. She is also a member of the Vasculitis Clinical Research Consortium and is active as a principal investigator on many clinical trials. Dr. Phil Sayo is the director of the Vasculitis Center at Johns Hopkins University in Baltimore, Maryland. Dr. Sayo is an associate professor in the Division of Rheumatology at Johns Hopkins Medicine. His clinical interests lie in the assessment and treatment of patients with systemic vasculitis, and in particular, ANCA-associated vasculitis, which includes GPA, MPA, and EGPA. I want to thank both of them for spending their Saturday mornings with us, and I will turn the floor over to them. Thank you.
So again, good morning. It's my great pleasure to be able to be here with you today and spend a little time discussing about the ACR Vasculitis Foundation guideline for the management of eosinophilic granulomatosis with polyangiitis. Just to mention again, we are going to be touching on some treatments that are not FDA approved, and I have been an investigator on some of the studies that this data has been based on. So again, familiar, I think, to all of you, but just to provide a very brief background, because it does reflect on how we view some of the recommendations that are made in the guideline. EGPA, formerly known as Churg-Strauss syndrome, is a form of vasculitis that affects the small blood vessels. It is considered within the family of ANCA-associated vasculitis, but important to recognize that only about 50% of people with EGPA will have a positive ANCA blood test. Men and women are affected equally. The average age is generally between 30 and 50, but we can see this at all ages. Now, commonly EGPA will be thought of as far as having 3 main characteristics, where we can see allergic, nasal and sinus disease and or asthma, which often begins in adulthood. We can see increased eosinophils, which are normal white blood cells that are seen at higher levels that may be present in the blood or the tissues. And we can see vasculitis or blood vessel inflammation, which can affect sites such as the nerve, the skin, the lung, heart, kidney, or many other organs. Now, in terms of the management guidelines, as Dr. Chung introduced, these were developed as a general guide for disease management, recognizing also the patient's clinical condition, their preferences, and their values should influence their treatment. The guideline, as Dr. Chung mentioned, was developed using a very structured approach. So this was not just a group of individuals who met in a room and discussed how they approached treatment, but there was a scientific methodology behind this, in which the core committee developed questions that were most important to physicians and patients. They examined the evidence from published medical studies. Then a team of physicians, together with patients skilled in vasculitis, reviewed the evidence and voted on the recommendations. And as Dr. Chung reviewed, the recommendations were rated as strong or conditional, which is based upon the amount of evidence. And this is a very important and tricky point, as far as just because a recommendation is made conditional, it doesn't mean that it is not something that people may feel strongly about. It just means as far as what is the amount of published evidence that is in support of this. And this has particular relevance to EGPA, as there have been very few comparative studies, say where one treatment was compared against another, such that there was a significant reliance on indirect evidence and expert opinion. So for EGPA, there were 15 recommendations and 5 ungraded position statements that were rendered. So how is this relevant and how does this apply to clinical practice? And really, very much the guidelines reflect how a doctor approaches deciding about treatments in relationship to someone with EGPA. The first step they ask is there evidence of active disease? If the answer is yes, the next step is deciding on a treatment to induce remission, which is often called induction. And the choice of that medication will be influenced by deciding about how severe is that disease. Is it severe or is it considered non-severe? And then a treatment is decided where the goal is to induce remission. After remission has been achieved, the next step is deciding upon a treatment approach to maintain that remission, which is often called maintenance. And of course, what we hope to avoid is a recurrence or relapse of that disease, which if it occurs, again, begins this cycle as far as how we think about this. Now, we can see that there are a number of medical terms that are mentioned in this approach. And this is not only important for us to understand today, but was very important for people to understand when they were developing the guideline and recommendations, because everyone needed to be on the same page. So active disease was defined as new, persistent, or worsening clinical signs and/or symptoms that were due directly to the EGPA. Severe disease would be vasculitis that was considered to be life or organ threatening, while non-severe disease would be not. Remission was defined as the absence of clinical signs or symptoms attributable to EGPA, and that could either be on or off of treatment. And a relapse would be a recurrence of that active disease following a period of remission. So let's see how the ACR Vasculitis Foundation guideline recommendations might apply to a couple of examples of people with EGPA. So this first individual is a 50-year-old man who is in the hospital and is being seen by his doctor. He has a long history of sinus congestion with nasal polyps. He'd undergone a sinus surgery where he showed a lot of eosinophils in the sinus tissue. 3 years ago, he developed asthma, which has been getting more difficult to control. And he came to the emergency room after developing trouble moving his right foot. Blood tested showed that he has a high level of eosinophils and increased inflammation markers. So these may be the tests you're familiar with that are called the sedimentation rate or ESR and the C-reactive protein or CRP. And further testing shows that his heart is not pumping well and has fluid around it. So again, medically, this would be considered a reduced ejection fraction with a pericardial effusion. So he is diagnosed by his doctor as having EGPA. And the next question the doctor is considering is what treatment should be considered. So the steps that we would go through as far as, does this individual have active disease? And the evidence is yes. And the next question is this severe disease? And so this individual, yes, has sinus disease and asthma, but some of the key concerns right now are the fact that there is evidence of nerve involvement as he's not moving his right foot. And particularly there are concerns regarding the heart as far as not pumping well and having this fluid around it. So this would be severe disease. So the doctor would be asking, in addition to glucocorticoids, which are prednisone and its relatives, which of the following treatments would he or she be considering as far as recommending for this man who has active severe EGPA? And the options may include medications like cyclophosphamide, also called Cytoxan, rituximab, or mepolizumab, also called Nucala. And so either cyclophosphamide or rituximab would be options, and maybe cyclophosphamide would be preferred because of the active heart involvement. So how this is reflected in the ACR Vasculitis Foundation guidelines is in an upgraded position statement that states that in patients with active severe EGPA, either cyclophosphamide or rituximab may be prescribed for remission induction. And the comments that were made regarding this position statement indicate that for severe EGPA, cyclophosphamide has been more commonly used, but some medical studies suggest rituximab may also be effective. Cyclophosphamide would in many instances be preferred for people for active EGPA involving the heart, as there have been more published evidence with this. But there may be severe active disease settings where rituximab may be considered, including in those individuals who are ANCA positive, who have active kidney disease, who have had prior treatment with cyclophosphamide, or for people with EGPA who wish to have children. So when we look at this, as far as this example really reflects, when you read the published guideline, what the physicians and other health practitioners would see is that there is a recommendation or an ungraded position statement that is followed by commentary as far as what the background was for it, what for some considerations would be for the health practitioner to consider, and what the published evidence has been to support it. So one of the questions, as you may have looked at this, you may have wondered, well, what about the option of mepolizumab or Nucala? There's good information about this medication being used in EGPA. And so what the ACR Vasculitis Foundation recommendation states is that for patients with active severe EGPA, we conditionally recommend treatment with cyclophosphamide or rituximab over mepolizumab for remission induction. And the reason for this is although mepolizumab is a good treatment that is FDA approved for EGPA, its effectiveness in people with active severe EGPA has not been established, as this disease setting was not included in the mepolizumab study. And again, the reasoning for this was based upon the fact that this was a newer medication, and the goals included not only demonstrating whether it was effective, but also assuring its safety, particularly, again, in those patients who had the most severe disease where there were proven treatments of benefit. So the good news for this gentleman is that his EGPA goes into remission. So the next question the doctor is asking is what treatment should be recommended for remission maintenance? And again, there are options such as methotrexate, azathioprine, also called Imuran, mycophenolate mofetil, also called Cellcept, or rituximab. And any of these are options. And again, what the recommendation of the ACR and the Vasculitis Foundation indicate is that for patients with severe EGPA whose disease has entered remission with cyclophosphamide therapy, we conditionally recommend treatment with methotrexate, azathioprine, or mycophenolate mofetil over rituximab for remission maintenance. And again, some of the discussion behind this recommendation is that although azathioprine is commonly used in EGPA, there have been no comparison studies between the three medications of methotrexate, azathioprine, or mycophenolate in being able to recommend one choice over the other. So this would be a decision that would be made between the person and their physician. There has been less experience with rituximab for maintenance in EGPA, but this could be considered if it was used for remission induction of severe active disease or if the other choices could not be used. So he elects to receive azathioprine for maintenance. 12 months later, he unfortunately has a relapse with severe active kidney disease, but he does not have recurrent heart disease. So in addition to prednisone, the doctor is considering the options of cyclophosphamide or rituximab. And so what the ACR Vasculitis Foundation recommendation states here is that for patients with EGPA who have experienced relapse with severe disease manifestations after prior successful remission induction with cyclophosphamide, we conditionally recommend treatment with rituximab over cyclophosphamide for remission reinduction. And again, the discussion behind this would be that there is a general desire to avoid retreatment with cyclophosphamide if possible, but also that cyclophosphamide may be considered in instances of recurrent heart involvement. So we're going to switch to one other individual, and this is a 48-year-old woman who was seen by her doctor. She notes a long history of nasal allergies, and 5 years ago, she developed asthma. 1 month ago, she developed a new red bumpy rash, and a skin biopsy was performed, which showed eosinophils and vasculitis. At that time, she also developed joint pain. Her blood tests show high eosinophils and increased inflammation markers, and further evaluation shows that she has normal lungs, kidneys, and heart. So she is diagnosed with EGPA, and now the doctor is considering what treatment should be considered for her. So once again, the question is, does she have active disease? And the answer is yes. And is this severe disease? And as we look at the profile, again, she has sinonasal disease, asthma, skin involvement, and joint involvement, but she does not have evidence of involvement that is affecting an organ or life-threatening feature. So she would have non-severe disease. So in addition to prednisone, the doctor is considering additional treatments for this individual with active non-severe EGPA. And the options may consider medications like mepolizumab or Nucala, methotrexate, azathioprine, mycophenolate, or the consideration of just using prednisone alone. So what the ACR Vasculitis Foundation recommendation states here is that for people with active non-severe EGPA, we conditionally recommend initiating treatment with mepolizumab and glucocorticoids over methotrexate, azathioprine, or mycophenolate mofetil and glucocorticoids. And again, the reasoning behind this was that mepolizumab was the subject of an important large comparative study and was shown to be effective in non-severe EGPA in this large comparative study. So this would be an instance where mepolizumab would be an excellent choice. So she knows that mepolizumab is a good treatment, but it is her preference to not take an injection medication right now. And again, this is the importance of shared decision-making between the person and their healthcare provider. So in this setting, the doctor is considering which option to consider now, in the setting where, again, mepolizumab is not going to be used. So what the ACR Vasculitis Foundation recommendation indicates in this setting would be that for patients with active non-severe EGPA, we conditionally recommend initiating treatment with methotrexate, azathioprine, or mycophenolate mofetil and glucocorticoids over glucocorticoids alone. So in considering this approach was favored with the goal of minimizing prednisone toxicity. However, the use of prednisone alone may be appropriate for mild asthma, people with allergic symptoms during pregnancy, or in other individual patient settings. So in coming to the end here, I wanted to show you, this is an actual figure that is taken from the publication that Dr. Chung mentioned that was published in Arthritis and Rheumatology earlier this year. And this is a schematic that demonstrates really the principles that we were just discussing. When a clinician looks at this, the first question they ask as far as, is this severe or non-severe active disease? And then they are provided with a series of options. There is then the discussion, has the person achieved remission, in which case there are treatment options for maintenance. And if there is relapse, again, options and how to approach this for management. There are some important points to keep in mind as we look at the management guidelines. The American College of Rheumatology and Vasculitis Foundation have stressed that these recommendations were made to provide physicians with information in the care of their patients and should not be used by any agency to restrict access to therapy or to require that certain therapies be used prior to others. So what this means is that there is strict emphasis as far as the decision about what treatments to be used should be made between the person and their physician. These recommendations were made as a general guide, and decisions about treatment will continue to be influenced by factors that are individual to each person with EGPA, and that may ultimately guide what approach is taken in treatment. And treatment decisions, again, should always represent shared decision-making between the person with EGPA and their physician. So with that, I will bring it back to Dr. Seow, and we'd both be happy to answer any questions.
Carol, thanks so much for that wonderful talk.
Let me get rid of my stop share here.
Oh, please.
There we go.
So let's start with a question of ANCA, just because you brought up ANCA in one of your early slides. I realize this is not specifically a guideline question, but I think patients often wonder if they're ANCA negative, is that a good thing or a bad thing?
Yes, so as I mentioned earlier, as far as, one of the challenging things with EGPA that gets a little confusing for both people with EGPA and physicians is that It is considered under our current nomenclature or naming system as far as within the family of ANCA-associated vasculitis, which is joined by the illnesses that Dr. Chung is discussing right now, granulomatosis with polyangiitis and microscopic polyangiitis. And there are certain shared features that are seen between the three of these entities, as far as that the kidney disease that occurs, also called glomerulonephritis, looks identical under the microscope. There can be similarities as far as the types of lung involvement that can occur, as well as similarities in skin vasculitis and nerve vasculitis. But EGPA has very unique properties that are related to the eosinophil in terms of asthma, eosinophilic inflammation in certain organs that make it very different. And that was why there was a different set of recommendations in the guidelines that were made for EGPA. Now, in terms of getting back to your question about ANCA, although again, it's considered in this family of ANCA-associated vasculitis, only about 40% of people will have ANCA present in their blood, which means the remaining 60% may not. And while there have been certain studies, again, from some of our colleagues in France and other studies that have demonstrated that there may be certain differences as far as some of the clinical manifestations that can occur in people who are ANCA positive versus ANCA negative, the approach to treatment I would continue to consider based on what are the disease manifestations that individual is presenting with, as far as what organ is being affected and how severely is it being affected versus whether someone is ANCA positive or negative. So again, I think it does get back to the guideline principles as far as thinking about, the first question is really disease severity and where it's affecting. ANCA really does not factor in a major way into that discussion as far as choosing treatments.
Terrific. Thanks very much. Now, to bring this back to the guidelines, just so that Joyce doesn't yell at me later, I wanted to know if you would mind just saying a few words about leukotriene inhibitors, just because I think I still answer questions about Singular all the time in my clinic. The guidelines specifically state that we conditionally recommend continuing leukotriene inhibitors over discontinuing leukotriene inhibitors. I was just wondering if you could comment on that.
Yes, no, so there are a class of asthma medications, and again, also used in the setting of sinus disease, called leukotriene inhibitors. And again, these are agents that you may be familiar with the trade name Singular, montelukast, as far as that are used again in the setting of asthma. And these can be actually very good medications in the setting of asthma and sinus disease. And after these were introduced, one of the observations that was made was that there were a small percentage of individuals who were on these medications who then emerged as far as having EGPA. And so one of the questions that came about, well, is there a cause and effect relationship between this class of medications and the development of EGPA? And the thought process as far as why we think this is unlikely, as far as is, again, these are medications that are used to treat some of the initial manifestations of EGPA, again, some of the sinus disease and asthma. And in some instances, this was effective enough that it allowed people who are on prednisone to withdraw from this medication. And in the setting of this withdrawal, it may allow the other features of EGPA to emerge. So the finding as far as there being a cause and effect relationship over the course of time as more experience was gained became less likely. And so for this reason, as far as the guidelines committee was evaluating this, one of the questions was asked as far as if you had someone with a diagnosis of EGPA who was doing well on these therapies, should that be stopped? And the evidence was thought to support that if they are doing well, there in the absence of a lack of a clear cause and effect relationship, that again, this could be a discussion between the physician and their patient as far as the option of continuing this if this was felt to be a beneficial medication.
Terrific, thank you. I'm going to ask you a question that's not completely fair, but it was passed along by Jen Gordon. So if you don't like it, you can blame her. Apparently, several people asked specifically about the role for avacopan for EGPA, and I was wondering if you'd like to make a comment on that.
All right. So again, I'm sure Dr. Chung is fielding a lot of questions in our sister session here on GPA or MPA. So some very recent news in those disease entities as far as has been the FDA approval of a medication called avacopan. And this is a very targeted medication that is specific for a protein in the immune system called C5a. And there have been studies in the laboratory, particularly in the setting of kidney disease, that have shown that this particular protein can make a difference in terms of how inflammation in GPA and MPA may evolve. So there was a recent comparison study that examined this medication as a role as far as being able to reduce prednisone in people who have active severe GPA or MPA. And it was found to be effective in that setting, such that the FDA recently approved this medication for the indication of severe GPA or MPA. So again, the question, I say many people with EGPA may have as far as, well, what about us with EGPA? And I think there are a couple of things to mention. Again, the studies that have been done at this point did not include people with EGPA. Some of the hypothesized mechanisms through which this may occur, may or may not apply to EGPA as far as, yes, some of the mechanisms in kidney disease may or may not be similar. But I would say the one area where it is probably quite dissimilar is part of the reason many people with EGPA have required prednisone has been for the manifestations of sinus disease and asthma, which appear to be very eosinophil driven. And this C5 protein does not appear to be involved in the pathway with the eosinophil. So, there would be concerns that, again, the main reason we want to spare prednisone in EGPA, avacopan, hypothetically would not really have a role as far as in being able to influence. So again, right now, there is no evidence as far as in using avacopan in EGPA. I think whether there are studies that pursue this really depend upon, again, the goals as far as what scientifically we were looking to do with it. But right now, again, this is not something that we would be discussing in the category as far as treatment for EGPA.
Great, thank you. There's a number of questions in the chat about the first guideline, which I knew would get a little bit of attention, where there was a recommendation to obtain an echocardiogram at the time of diagnosis. Because I'm betting there's at least a few people on this chat who have not had an echocardiogram performed at that time. I was wondering if you could talk a little bit about why that recommendation was made.
Yes, so one of the things that we recognize from reading the studies as far as that have been done, looking at a large, relatively large number as far as people with EGPA studies from France, from the Vasculitis Clinical Research Consortium, is that heart involvement is one of the manifestations of EGPA that can really influence how a person does. And the heart can be affected in EGPA in a variety of different ways. Again, one of the things we tend to think about as far as when we think about heart problems or we see commercials on the television as far as, people having, heart disease or heart attacks, which is one of the most common things in human life. That can happen in EGPA, but it can affect the heart in many other different ways. Again, where the eosinophil can affect the heart muscle, where you can get fluid around the heart. Again, this pericardial effusion that the gentleman in the first example had. And in some instances, people may have no symptoms of this. So again, they may feel very unwell as the result of their asthma or their sinus problems or their nerve involvement, such that, again, they're not really manifesting features of their heart. And so because of this, the echocardiogram, which is an ultrasound of the heart, they basically rub a wand over the chest to look for how the heart muscle is pumping. They look for fluid around the heart. They look at the valve. This can provide some helpful information. So if we find some evidence that the person has no symptoms of as far as heart involvement with EGPA, that would influence our treatment decisions as far as whether that individual may fit in, again, that branch as far as where there is severe versus non-severe disease. So heart involvement would fit in the severe category. So that's why, again, we favored, since this was a simple, non-painful, non-invasive test, that it could provide useful information. Now, fortunately, the vast majority of the time, we are not going to find any worrisome findings. But, in the rare instance where we might, that can provide useful information. And it can also be an important baseline study moving forward to know for that individual's history.
Terrific, thank you. The guidelines mention mepolizumab specifically a few times. And as you know, mepolizumab is just one of the anti-IL-5 agents that we have available, which include benralizumab and reslizumab. Should the guidelines be interpreted as taking a stand on this? Is mepolizumab really the drug of choice in these cases?
Well, to date, mepolizumab is the only agent that has been studied, in a clinical study situation or a clinical trial, as far as where, again, a group of investigators have used this in individuals in appropriate settings who have active EGPA, and then examined its effectiveness and its safety. So while there are other medications that have similar properties as far as how they affect, again, this protein called IL-5, which again is involved with the eosinophil, again, we just don't have information from clinical studies to demonstrate how effective this is and how safe it is in this setting of EGPA. Now, these are medications that are FDA approved for other indications, such as eosinophilic asthma, but they have not been specifically studied in EGPA. And as Dr. Chung mentioned, during the introduction, how the guidelines were developed were based solely on published studies where there's been scientific evidence of efficacy or effectiveness and safety in demonstrating to be used in the guideline preparation and recommendation. So that's why you don't see, as far as these other agents that have similar properties, but for which there's been no published evidence being used in the guidelines.
Great, thank you. As you mentioned in your presentation, the guidelines don't take a stand on rituximab versus cyclophosphamide. And certainly it's not hard to imagine patients for whom rituximab would be a desirable agent. Are there still patients for whom you would strongly recommend the use of cyclophosphamide over rituximab?
So, for me, I think the one setting where I would still consider this, is in heart involvement. Again, the amount of published experience that we have in this setting remains relatively small. And again, there has been no comparative study between cyclophosphamide and rituximab showing that one is more effective than the other, and including in heart involvement. But it's just because this is such a severe manifestation that would be a setting as far as where I think cyclophosphamide, the published experience that is out there, would tend to favor its use. Again, others may argue, as far as if there was something like brain involvement, that may be a setting where they would personally consider cyclophosphamide more over rituximab. But again, I think the reason that these were put equally in the guideline, as far as is that there are pros and cons of each of these medications, risks and benefits. And I think in any discussing, that a doctor would have, with the person with EGPA, that those would be discussed as far as what is the medical evidence or what is not that evidence, as far as where we have areas of gaps, what are the side effects of those medications, and what that might mean in the immediate period as well as in the future. So yes, I do think there are still settings where cyclophosphamide would probably be my preferred agent of choice, but again, it's going to be very, individually driven.
Thank you. I guess another question I have is, do you have a favorite guideline? Do you have a recommendation that you think would be particularly useful for the clinician who maybe doesn't see EGPA on a regular basis?
I don't know that I have a favorite. I think the things that reading the guidelines, provides as far as is sort of a thought process, as far as, even getting back to the concept of as far as thinking about the echocardiogram, as far as, getting us to think about, again, what are the manifestations that are occurring? Are we convinced that this represents active disease? Because there are settings where, again, if someone, say, is on prednisone or other medications that suppress their immune system, and they develop, say, a cough and what we call infiltrates in the lung, which you may see on an X-ray, as far as is that actually an infection. So it makes, us as healthcare providers think about, is this in fact active disease? Where is this affecting as far as what organ sites and how severely? And then thinking about a stratification about, what type of treatments should we use, thinking about their pros and cons, what is the evidence of published data and how strong is it, and how to be able to structure that in our discussions with each individual person based upon, their healthcare history. Have they had relapses? Do they have reasons why they cannot receive a certain medication? So again, such as a medication like methotrexate, which we cannot use in people whose kidneys aren't working well, or the medication mycophenolate or Cellcept, which we would not want to use in a woman if she wished to have a child soon, as far as since this is contraindicated in pregnancy, as is methotrexate. So it gets us thinking about the individuality of each person and how we might or might not apply these guidelines. So I think it's useful in providing a structured approach to management and where to begin some of our discussions with the people we care for.
Great, thank you. Thinking about the guidelines, do you think there are any of the recommendations that will age more quickly than others? Or are there certain recommendations that you think are going to be ripe for revisiting in the next several years?
Yeah, I think a great number of them will be ripe for revisiting, and say that's the great news, actually, in many ways in all of vasculitis, is that there is, such a tremendous international effort that is taking place in which we are seeing advancements all the time. So in a sense, it's great news that these will be outdated, hopefully in, the sooner rather than later basis, and require updating. I think as far as some of those that we may see some of the greatest changes over, as far as is, we are doing a lot of work in the laboratory to understand some of these mechanisms that occur with the eosinophil, with other pathways involved in the immune system that may be contributing to vasculitis. So again, examples of that are what you've heard discussed here about mepolizumab and even the avacopan medicine that was raised earlier. And as we understand if there are critical proteins or cells involved, medications will be developed that target those that will then be investigated in studies. So I think that's where we're going to be seeing, hopefully some of the, ripest development where we may have treatment approaches that have effectiveness and also improve safety.
Thank you. There was a specific question about the role of IVIG, which I realize is not in the guideline, but I'll ask it anyway. Do you have an opinion on whether or not IVIG is indicated or contraindicated in EGPA?
Yes, so IVIG, or again, the long name is what's called intravenous immunoglobulin.
Did Dr. Langford freeze for everyone or just me?
Frozen. Maybe she'll come back in a minute. Maybe, Dr. Seaman, do you want to try to answer the question in the meantime? Oh, she's back.
I just saw her move again. Dr. Langford, you just faded out, but I think you're back in.
Oh, okay. I'm sorry. Goodness.
No, it saves me the trouble of trying to answer my own question. That's great.
All right. So I don't know what point that cut out. I'm sorry. Yeah. So IVIG, again, intravenous immunoglobulin, is our natural protective proteins. In a sense, this is a blood product. As far as when people donate blood, there are many different components that are taken from this, including red blood cells, clotting cells, plasma, and one of those is immunoglobulin. And so this product is used for a variety of reasons. There are people who are born with reduced levels of immunoglobulin who need this as a replacement to prevent infections. And it has also been used medically as a treatment in certain settings. Now, the times that these have been used in vasculitis and in EGPA would be often in people who maybe have an active infection themselves and where the use of other medications that suppress the immune system may be felt to be too risky. This is one of the medications that we can actually fairly safely use in this setting because it's not thought to suppress the immune system as far as affecting the person's ability to fight off infection. So that would tend to be the main time that I would use this. Again, the other instance that this tends to be used in vasculitis is if people do have low levels of these protective proteins or IgG levels, where again, it may be given at what's called replacement doses to be able to help reduce their risk of infection. So yes, I would say it's not a commonly used medication in EGPA, but it can have utility in certain selected settings. So when do you use it, Dr. Seow?
As you said, I do what you do. I often will use IVIG in a patient with severe vasculitis as a bridge where I feel that other agents I might rely on, like rituximab or cyclophosphamide, might be too risky. And at the other end, of course, there are unfortunately some patients who develop CVID who need IVIG at a low level in order to keep their immune system functioning. So I basically do what you do.
Great.
So moving along, the fourth recommendation is about using pneumocystis prophylaxis in patients on cyclophosphamide or rituximab. And my colleagues in oncology always take me to task over this because they use rituximab all the time and they don't typically use pneumocystis prophylaxis for those patients. I was wondering if you could talk about that.
Yes, so, Dr. Chung mentioned this also in her introductory comments as sort of an example of something that is a conditional recommendation, but something that most of us actually feel quite strongly about, in the vasculitis world. And again, pneumocystis is a type of lung infection that can occur in people who have suppressed immune systems. And again, normally, this is an organism that lives around us all the time. And normally, again, we're able to fight this off very well. So this is not a typical cause of lung infection or pneumonia, but it can occur in people who, again, have suppressed immune systems. And the reason this one gets our attention is because it can cause such a severe lung infection or pneumonia. And also because it is preventable by using this prophylaxis. Again, the most common form of pneumocystis prophylaxis is trimethoprim sulfa or Bactrim, which is a sulfa-containing antibiotic. For people who cannot take sulfa, there are other options as well that can be used. But again, I think part of the difference as far as is why we're sensitive to it is we have seen this, in upwards of 10% of people who have received, again, induction treatment. Now, I think one of the differences between what we do and what they do in the cancer world is most of our treatments, particularly in the setting of severe vasculitis, includes a combination treatment where someone receives something like cyclophosphamide or rituximab, but it is also combined with high dose of prednisone. And that, I think, makes a difference as far as that is impacting multiple different parts of the immune system, which increases the risk of pneumocystis. So I think that is one difference as far as what we do tends to what they do in the cancer world, and why we may see a higher rate of pneumocystis that occurs. But again, yes, I think that's why we tend to feel, fairly strongly that this is an important part of treatment. And, anything we can prevent is a good thing.
Great, thank you. Where do you see the clinical need? If you had $5 million and you were able to design any clinical trial to examine any question looking at EGPA, what would you target?
Oh boy.
Yes, as rheumatologists, we very rarely think about having limitless amounts of money, but yes.
Yeah, no, and I hate to say $5 million would probably still not be enough for a good clinical trial, but I think, again, when we think about things related with EGPA specifically, again, the eosinophil is what is unique to this disease as compared to GPA and MPA and other forms of vasculitis for that matter. So, I think that, there is research that is going on right now at a number of labs across the world, really trying to understand more about eosinophil biology. So I think that still is where, as far as in this illness in specific, as far as where there may be answers as far as to be gained, as far as looking for that. So, I think that is a useful area.
Great, thank you. There was another question that's not exactly about the guidelines, but I think it's interesting regardless, about whether or not these diseases are familial. So if a patient has EGPA, should anyone in their family be concerned about developing either EGPA or another form of vasculitis?
Yeah, so this is obviously a very important question, that all of us would have as far as in thinking about our loved ones. And again, it's not uncommon when you talk to people with vasculitis, as far as that they will say things as far as, again, this is vasculitis is considered within the much broader family of illnesses that are considered autoimmune. So again, where our own immune systems, are affecting our own natural tissues and organs. And there are a lot of different illnesses that are within the autoimmune disease family. And, all the time, as far as there are increasing entities that are considered to have at least some autoimmune component. So again, it's not uncommon that when you talk to people with vasculitis, they will say, oh, I have a cousin with rheumatoid arthritis, or an uncle with lupus, or, something as far as other causes of autoimmune disease. So I would say it's not at all uncommon that people who have one autoimmune disease may have other members of their family with an autoimmune disease. But as far as, again, a direct tracking, as far as where, a parent to child or a brother to sister would have another form of vasculitis or the same form of vasculitis, the studies that have been done have not suggested a direct hereditary component. Now, that's not always the easiest to do, and there have been some studies that have been done in some of the smaller countries in Europe where they are able to track national records and familial links a bit more easily than us in the United States, where we are such, a blended population. But from the studies that have been able to be done, again, they have not suggested that vasculitis has direct hereditary links. Now, that doesn't mean that we haven't continued to look closely at the issues as far as genetic inheritance. And there have been a number of studies that are ongoing that are continuing to do that. And again, many people have participated in studies to be in a larger, genetic repository, so that when the science is there, we will be able to do these types of studies. But again, that is probably going to be a much more complex issue as far as how our individual genes may interact with our environment, potentially influencing how we develop illnesses. But again, as far as thinking about our loved ones, no, the evidence has not suggested a direct hereditary link.
Carol, I'm just going to ask you one more slightly unfair question, and then I'll give you a chance to make any wrap-up comments you like, and then we'll give you a few minutes before you have to give your next talk. The slightly unfair question is, do all flares of EGPA associate with increases in eosinophil counts?
So the answer is no. But again, there's a lot of different things that will depend on that as far as, the eosinophil is exquisitely sensitive to prednisone and its relatives. So if a person is on a certain degree of prednisone for, say, their asthma or their sinus disease, then their eosinophil count may be normal. But again, the eosinophil, while being very important, is not the only important thing. And that's, again, some of the pathways that we need to understand more about, as far as that we could still see other vasculitic manifestations that could emerge even in the setting where the eosinophil number is normal. The other thing to keep in mind is what we can measure is what we're seeing in the blood. And that's what we can easily look at. We can't just do biopsies of different organs to see if eosinophils are there. So, we're at the mercy, in a sense, of looking at what we can do safely, which is to analyze eosinophils in blood. But that may not tell us the whole story about what's occurring within the actual tissues themselves, where there could actually be eosinophils present that are causing trouble in that setting.
Great, thank you. Carol, do you have any final messages for the group before we wrap up?
No, I think really only that, we thank you for your interest in attending this session this weekend, because we realize this is your weekend as well. I think one of the important things really to all of us, as far as those of us as caregivers and certainly the Vasculitis Foundation, is that we feel very strongly, that knowledge is empowering, and you're being here to try and understand more about EGPA and more about the guidelines, is a very important part of our mission in trying to, extend information about vasculitis, and to be able to see how we can, disseminate this information that can be meaningful to people with vasculitis. So we really appreciate your time this morning in helping us to do that.